Good afternoon. My name's Peter Odor. I'm an anaesthetist at University College Hospital. And I've been given the important but challenging task of summarising in 10 minutes the evidence base for preventing respiratory complications after surgery. Important because respiratory complications after surgery are common. In fact, they're more common than cardiac complications after surgery. Yet they're also associated with significant healthcare utilization costs after surgery, again, more than for cardiac complications after surgery, yet the evidence base is far more disparate and challenging to interpret. And in fact, we don't have good standards of care or national or international consensus guidelines for postoperative pulmonary complications or PPCs in the same way that we do for cardiac complications. And part of the reason for that is that the evidence base for PPC prevention is huge and discordant and covers hundreds of trials. In fact, covers dozens of different definitions for PPCs as well. So even the most fundamental outcome measure, we've only very recently been able to agree upon a set of standardized definitions. Firstly, by a European Society of Intensive Care Medicine group, and then secondly by the STEP group, which also incorporates some severity grading for conditions like atelectasis and respiratory failure and respiratory infection. And there's also a lack of comprehensive evidence synthesis for PPCs as well. And in fact, the last comprehensive systematic review providing an overview of treatment strategy efficacy is now 13 years out of date and based on quite out-of-date models for writing guidelines these days as well. And amazingly, we've got to the afternoon of a quality improvement conference and no one's mentioned Edward Deming yet. So I'm gonna complete the cliche and say that uncontrolled variation in practice is the enemy of quality, and that's exactly what we see with management of PPCs for patients. And part of what I've been involved in for the last few years is trying to redress this imbalance and take data from well over 100 different randomized controlled trials for perioperative strategies for preventing postoperative pulmonary complications and trying to provide an objective synthesis, an objective overview of relative treatment efficacy. And some of what I'm going to talk about over the course of the next few minutes is derived from that review, but also from other sources and meta-analyses and longitudinal studies. So I've got 3 slides. Each slide is a different phase of the perioperative journey for patients, and I've divided it up into what I think are controversial statements, or those based upon low grade of evidence, and those that are based on relatively higher grades of evidence. And as Ramani's just been talking about, I think the first step in tailoring the perioperative pathway for patients begins with risk assessment. And by far and away the most important risk assessment or variable for patients is procedure related. So it's the site of the surgical incision. This is very predictable. And actually upper GI surgery and lower GI surgery and thoracic surgery all put patients at much higher risk of PPCs. What's slightly less intuitive is the patient-related risk factors. And it appears that it's more the functional impairment that a particular disease or pathology presents to a patient that's more important than just the presence or absence of disease. So mild or well-controlled respiratory disease like asthma or COPD actually is a relatively minor risk factor for development of postoperative pulmonary complications. It's more the uncontrolled disease that's a significant factor. Surprisingly enough, over the last few years, it appears that smoking is less of a risk factor than we previously thought, the last meta-analysis, but the risk of PPCs at those who smoked within 12 months of surgery at an odds ratio of 1.3, so not significantly higher than for non-smokers. Obesity per se is not actually a risk factor for developing PPCs, but more it's the presence of impairment in functional capacity that's brought about by obesity that's related to risk. So obesity that causes obstructive sleep apnea or pulmonary hypertension or obesity hyperventilation syndrome is definitely a risk factor for PPCs, but actually just having a BMI over 40 doesn't actually necessarily present an increase in risk. ASA, despite being a relatively blunt tool, still appears to offer some discriminatory value for predicting PPCs. And then the exception to this rule is age. And age over 60, irrespective of comorbidity status, appears to be a risk factor for PPCs. And that's unlike with cardiac complications, where if you tease out the influence of other comorbidities being more common with age, it doesn't appear to be particularly relevant. So healthy, older patients are increased of post-op pulmonary complications. And surprisingly enough, supported by most of the preoperative evaluation guidelines, is that routine prophylactic ABGs and chest X-rays doesn't add anything to risk prediction or profiling for chest complications. And you may or may not be aware, but the PQIP dataset actually includes the set of variables that are required to calculate an ARISCAT score for your patient. The ARISCAT score's a risk prediction tool for PPCs. It's developed in Spain and validated European-wide. That's got good discriminatory ability for predicting high versus moderate versus low risks of PPCs for patients preoperatively. But unfortunately, there aren't any longitudinal studies yet that state that predicting risk in advance makes a difference to your outcomes postoperatively. And slightly more controversially is what we do about these patient-related risk factors. And I've put what I think is probably the fairest statement I can, which is delay or non-time critical surgery to a patient's at their best. And actually, there's very little evidence that hyper-treating a patient's respiratory morbidity before surgery, so giving excessive steroids or excessive bronchodilators, makes any difference afterwards. So treat them as you would a normal non-surgical patient. The jury's still out on time of smoking cessation, but probably greater than 8 weeks is round about the right time. And there's actually very poor evidence for randomized studies around smoking cessation timings. So intraoperatively, what do we do? So there's building evidence that simply dialing up slightly different settings on our ventilator makes a difference to post-operative pulmonary complications for high-risk patients or those having prolonged surgery lasting more than 2 to 3 hours. And that's a low-cost strategy. It costs nothing to set the right settings for your patient intraoperatively. And we've got the same parallels with intensive care management for ventilatory practice as we do now for intraoperative. What's less clear is exactly what represents the optimum protective ventilation strategy. And if you look at mediation analysis for the more than 20 trials that have been conducted in this area, then it's probably something to do with plateau pressures, or rather driving pressures. So the difference between plateau pressure and PEEP. But there's no trial yet that has tested individualizing driving pressures as a target intervention for preventing post-op pulmonary complications. Do we know whether these strategies that we apply for high-risk patients having major surgery or long surgery, do they apply for ambulatory surgery? We don't know at the moment. Probably not. And what do we do for specific groups of patients with lung ventilation or morbid obesity? Again, there isn't the trial evidence to support that at the moment. Data from particularly from the MASTER study in Australia, supports the notion that epidural analgesia preserves respiratory function after surgery and provides superior PM relief. And that has a knock-on effect in reducing post-operative pulmonary complications as well. But again, epidural analgesia isn't suitable for everyone. And there's a whole list of costs and implications to weigh alongside that particular benefit. There's now more than 20 meta-analyses that have shown that in some way or another, goal-directed hemodynamic therapies reduce the risk of morbidity following surgery. And the same is true for respiratory outcomes as well. But this is a relatively small effect size, so you probably have to treat 50, 60, 70 patients to prevent one PPC after surgery. There's a lot of historic data that's led to physiotherapy being probably rightly entrenched as part of our perioperative pathways for major surgical patients, but actually very little recent randomized evidence So there's actually been 14 studies over the past 20 years, most of which have been small, of less than 100 patients, and have shown no significant benefit to respiratory physiotherapy. There's 2 exceptions. Both of those exceptions involved what I think is becoming a more trendy approach to risk mitigation, which is prehabilitation. So both of those studies involved preoperative respiratory interventions as well as postoperative trials of 700-800 patients, which did show significant reductions in postoperative respiratory infections. That's a complex intervention. It's a costly intervention, and much like intraoperative ventilatory practice, there's a lot of variables to consider. I don't think we've got clarity yet on exactly which physiotherapy parameters are the right ones to intervene with our patients. And there's a number of other lung expansion modalities that there's some growing evidence for. Post-op CPAP has got some low-quality evidence of benefit across about 700-800 patients worth of randomized studies in meta-analysis. And of course, the PRISM trials just very recently recruited its 4,000th patient and should be closing fairly soon and give us a clearer idea about whether 4 hours worth of post-operative CPAP makes a difference to respiratory function. Rather disappointingly, there's moderate quality evidence that just providing a patient with an intensive spirometry device actually doesn't reduce their risk of post-op pulmonary complications. So take-home messages. So PPCs have got a major effect on healthcare utilization and morbidity and mortality after surgery. We may be able to benefit our patients by risk stratifying using tools like the ARISCAT preoperatively, but currently longitudinal studies don't actually suggest any definite evidence of benefit, but it's a logical approach, it makes sense. As I've shown you, there's variable quality evidence for both preoperative, intraoperative, and postoperative strategies to reduce PPCs, but it's a rich tapestry. I've presented some headlines today, and actually the detailed narrative of that is, as you'd imagine, much more complicated. And it's probably, that complexity is borne out in the lack of really clear standards or guidelines. Unlike many things, I suspect that the solution lies in context-sensitive approaches and looking at local multidisciplinary working and working out what at a local level sites do well and do less well. And perhaps speculatively, I could say that building in bundles of care or looking at evidence-based interventions together synergistically, where they may offer some benefit. And there's a couple of trials, both from the UK and the US, that have shown some limited support for that type of management approach for patients as well. That's all I've got to cover for this subject. Thank you very much for listening.